Good morning, and thank you for joining us for the Safety Center's October webinar, A Public Health Approach to Rural Transportation Safety. We're going to get started now. I'm going to close out all these polls on the right-hand side and display the results so that you can see those. It looks like most people are joining us today by computer only. For those of you who are joining by computer only, if you do have any audio issues, we would ask you to dial in via phone. The phone number can be found at the top left-hand corner of your screen. It looks like we have a pretty good cross-section of representation today. We have 40% of people from other federal, state, or local government agencies. We have about 12% from the universities, 12% private consultants. We have about 6% local transportation departments, 15% state DOT, and about, it keeps moving, sorry, about 5% from federal DOT. And then it looks like, as always, most of you are joining us all by yourselves in a room, but we do have a few of you who are joining us in groups. And like normal, we would ask you, if you are joining us in a group, if you could please send an email to info, I-N-F-O, at ruralsafetycenter.org and let us know the names and email addresses of those that are in your group that have not registered by themselves for today's webinar. And that will be to ensure that we can get you certificates of completion for today's webinar. It also looks like we have about 30% of you joining us from the Southeast. And again, about 33% from the West, 20% from the Midwest, and about 8% from the Northeast today. So we're glad to have all of you today at our webinar. I'm going to move us over to our presentation itself. So just a few webinar logistics for you guys. The webinar will be about an hour and a half long today. As always, it is recorded and will be archived on our website within a week. For quality of today's recording, everyone's phone lines have been muted. If you are listening via phone, please make sure that you mute your computer so that you will have no feedback. And again, if you're listening by computer only and if you have any audio issues due to the Wi-Fi connection, go ahead and call in. The phone number is at the top left-hand corner of your screen. Also, to maximize the presentation, if you'd like to make it bigger, there are 4 arrows that press outward on the right-hand top corner of your screen, and that will make your screen full screen so that you can see it a little bit more clearly. At the end of each section today, we will have time for question and answers. But at any time, you can feel free to put those questions into the chat pod, and when we do reach the question and answer time period, I will read those out loud to our presenter. So as I mentioned, you can feel free to go ahead and type those in at any time. There is also a handout pod that I mentioned before on the bottom left-hand corner of your screen, and that is a PDF version of today's presentation if you'd like to download it. It will also be posted on our website with the archived version of today's webinar as well. And then lastly, we will have 2 follow-up surveys that you'll be getting. The first survey will come out later today, and it will have some general questions about the content itself and about our presenter and about the technical capabilities of our webinar system itself. It will also ask you if you're interested in receiving a certificate of completion, and it will ask you if you would like the form to fill out to request CEUs for today's webinar. In about 3 months, you'll receive a separate survey, and that survey will ask you more specific questions about what you did with the information that you learned in today's webinar. So we're looking for information about whether or not you've gone and reviewed any of these resources that will be spoken about today, if you've implemented anything based on today's webinar, if maybe you've shared it with someone else after today's webinar. So those are the types of things we're looking for in that second survey. Today's presenter, we're very lucky to have Laurie Beck with us from the Centers for Disease Control and Prevention at the National Center for Injury Prevention and Control. And she's going to provide us with some great information about what the CDC is doing in transportation safety and some of the great resources that they have available. Laurie Beck is an epidemiologist with the Division of Unintentional Injury Prevention in the Centers for Disease Control and Prevention. the National Center for Injury Prevention and Control. She has been responsible for research and programs in transportation safety for almost 15 years and focuses primarily on seatbelt use and safe transportation for older adults. Prior to joining the CDC and the NCIPC, she worked on a public health surveillance system in the field of maternal and child health. Ms. Beck has a BA in sociology from Wake Forest University and a Master of Public Health in Behavioral Science and Health Education from the Emory University Rollins School of Public Health. And just before we get started with some of this, I did want to have one poll question to check out how much you guys have heard of the CDC. So have you ever heard that the CDC works to address injury prevention before? Yes or no, if you could just let us know that. And this question, we're just hoping will give our presenter a little bit better understanding of who her audience is today. It looks like at this point that everyone has filled it out, so I'm going to go ahead and broadcast those results. It looks like about 81% of people have heard that the CDC works to address injury prevention. So the goals of today's webinar is that once you've completed our webinar, you will be familiar with the public health approach to motor vehicle injury prevention, particularly prevention strategies that target the road user behaviors. To achieve this webinar goal, you will learn two specific things. The first is to summarize the public health approach to motor vehicle injury prevention, and the second is to identify CDC resources, tools, and programs that can support transportation safety efforts in rural communities. And again, we will be having 2 question and answer periods, but you can feel free to put questions into the chat pod at any time. And at this point, I am going to turn the presentation over to Laurie.
Hi, thanks, Jamie. Everybody can hear me?
Yep, we can hear you great.
Okay, thank you. I'm really excited to be here. I was happy to have the invitation to come and speak to all of you today. And as Jamie said, I do work at the CDC, and I'm going to talk first here about the public health approach to motor vehicle injury prevention. It's exciting to see that about 80% of you already are familiar with CDC's injury prevention work. Just as a side note, our Injury Center is celebrating its 25th anniversary of its existence as a center within CDC this year. So we're really excited about kind of everything that we've accomplished so far and everything that's yet to come. All right, okay, so first just to give a quick overview of what the CDC is and kind of where injury prevention fits into all of that. What is the CDC? So we're the nation's leading public health agency. Our mission is saving lives and protecting the health of Americans. We're headquartered in Atlanta, but we do have facilities throughout the U.S. We have field staff who work in all 50 states at health departments at the state level. We're in D.C. and the territories, and we also have staff that's permanently stationed in more than 120 countries around the world. So we're a large organization, and our basic role is detecting and responding to new and emerging health threats, tackling the biggest health problems causing disease and disability for Americans, putting science and advanced technology into action, promoting health and safe behaviors in communities and environments, and developing leaders and training the public health workforce, and taking the health pulse of our nation. This is an organizational chart, and I know there's kind of a lot here to look at on the screen, but I just wanted to give a sense of kind of how the Injury Center fits in. I have the Injury Center highlighted with the blue circle, and we're one of about a dozen centers and institutes within CDC that focuses on a specific sort of health area. And so the Injury Center covers unintentional injury prevention, including transportation safety, and also violence prevention. Okay, so what is the public health approach? We use this 4-stage public health model to guide our work across the agency, and this is true from infectious disease to environmental health, from chronic disease to injury prevention, and the same framework guides our work across all of these areas. In this model, we move from, at the number 1 point, from traditional surveillance, and that is assessing what is the problem, to identifying causes and risk and protective factors, to development and implementation and evaluation of programs and policies. And finally, we aim to bring proven evidence-based interventions to scale. And so as we walk through the different activities in CDC's motor vehicle injury prevention portfolio throughout the presentation, you'll see each of these stages represented in the work that I share. And now I just want to focus in for just a second on CDC's rural health work specifically. So throughout the agency, we do work on rural health topics. And this year, CDC's kind of put forth a special effort to highlight the issues around rural health and increase awareness of kind of the what's happening around the agency and around different diseases and injuries. And so this is a new web page, kind of landing page for all of rural health work within CDC. One of the things that we're doing around this effort is publishing a series of reports in the Mmwr, and that's the Morbidity and Mortality Weekly Report, which is the CDC's publication on kind of emerging issues, outbreaks, high importance issues. And so we're publishing a series of reports on rural health this year throughout 2017. And by the end of the year, there will be a total of about 12 reports that have been published. One of those is on motor vehicle safety, and I'll talk about that in the next section of this presentation. But I just wanted to let people know that this webpage exists as kind of the first stopping point for rural health for CDC. And there's constantly being new material added here. CDC as an agency has set its own priorities, and we refer to these as winnable battles. And you can see here the list of priorities for the agency at the that were set in 2010, I believe. And motor vehicle injury prevention is one of those. So these priorities were selected based on the fact that A, they represent a major public health burden for the nation, and also the agency thought it was important to focus in on areas where interventions are available that have been shown to work and that could make a real difference in health outcomes if they were more widely implemented. So why was motor vehicle safety chosen as one of the priority areas? The next few slides will give a little bit of data that is probably familiar to a lot of you in terms of motor vehicle injury and the impact on the nation. So this chart shows the 10 leading causes of death by age group for the United States, and the colored boxes are injury-related causes of death. So the blue boxes are unintentional injuries. These include motor vehicle traffic crash deaths and also include unintentional overdoses, residential fires, falls, and other unintentional causes. And you can see that unintentional injury deaths are the leading cause of death from the ages of 1 to 44. And then the red and green boxes are homicides and suicides, respectively, which is another area of focus for the Injury Center. And here we're drilling down and looking specifically at injury deaths. And these are the 10 leading causes of injury deaths by age group. And here the colored boxes are representing unintentional injuries, with the blue boxes being motor vehicle traffic deaths. So you can see that motor vehicle traffic deaths are the first or second leading cause of death for ages 1 through 65 plus and I should clarify if I didn't say this correctly, the leading causes of injury-related deaths specifically. And as we all know, the deaths are not the entire story here. So for every one person who's killed in a motor vehicle crash, 8 people are hospitalized, and 100 people are treated and released from the emergency department. So for this reason, CDC's Injury Center does have a transportation safety team that's dedicated to this issue. Our vision is to keep people safe on the road every day, with our mission being to reduce injury and death due to motor vehicle crashes and promote safe travel. And we basically envision motor vehicle injury prevention as kind of encompassing one of these 4 pillars of intervention, which safer roads, safer vehicles, safer road users, and improved post-crash response. CDC's work is primarily focused on safer road users, and so we use the public health approach to really primarily look at road user behavior, such as buckling up, wearing a helmet, not drinking and driving, and so on. These are our priority areas for motor vehicle safety: restraint use for adults and children, impaired driving, tribes, older adult mobility, and data linkage. And that kind of wraps up my first section on kind of what is CDC and what's the public health approach.
Perfect. Thank you very much, Laurie. And so again, it is time to take questions. If anyone has any, please go ahead and type those into the chat pod. I'm going to move us over to our first poll break, but you will notice that the chat pod will still be on the left-hand side as well. So we do have 3 questions for you at this time. The first one is, which of the following is not one of the CDC transportation safety priority areas? Is it restraints, impaired driving, tribes, older adult mobility, data linkage, non-motorized transportation? The second question is, the 4 pillars of transportation safety intervention are safer roads, safer vehicles, safer road users, and improved post-crash response. Is this true or false? And the last question we have for you is no longer there. Dana, could you take a look and see maybe what happened to our third poll question, please? But in the meantime, if everyone else can please go ahead and fill out those first 2. Laurie, it does look like we have a few questions coming in, so while everyone is entering in the poll questions, I'll go ahead and have you answer one of those for us. The first question is, can you talk a little more about the data linkage priority area?
Sure. This is a newer area for us, and so we've kind of been, one of the things that we always struggle with is kind of getting a complete picture of, what's contributing to motor vehicle crash injuries and deaths. And, we've got, very broadly speaking, kind of health-related data from medical sources like death certificates, hospital data, discharge data, stuff like that. And then and that gives us a really good picture of what kinds of injuries are sustained, what are the outcomes and sequelae from all of those medical injuries. And then on the other side, there's, a lot of data around on the traffic side and transportation side relating to the crash itself. And so the idea of data linkage isn't new to CDC, but one of the things that we're trying to do is really look at, if we can do some data linkages between sort of the crash event and the medical outcomes, can we get a better picture of what's going on and how to prevent injuries. So the Department of Transportation has done some work in this area that probably a lot of you know about and are familiar about, we're starting to look at it more heavily as well. We have some information on our website about kind of, I would say, guidelines about data linkage and how to do it, and they're just things to consider when we're doing data linkage. And then we're also trying to take a look from a public health perspective, can we really promote the idea and the importance of having this linked data and how it can help the public health side. So we've actually recently begun a project with through some funding to universities to look at some data linkage work specifically around the area of older adults, and we're hoping that this will kind of serve as a model and show what the benefits are, and then we can expand our work there.
Perfect. Thank you very much for explaining that. We do have all the answers in for the poll questions now, and I have closed those out and broadcast the results if you'd like to go ahead and address those 3 poll questions, please.
Sure. It looks like most people answered correctly on the questions. Yeah, not 2/3 of people correctly answered that non-motorized transportation is not a priority area for the transportation safety team. That's correct. I mean, it is one of the issues related to transportation safety, but in terms of everybody's familiar with kind of setting priorities and looking at resources and where we can make the most impact, our safety team has chosen to look at prioritize restraints, impaired driving, tribes, older adult mobility, and data linkage. And looks like pretty much everyone got the 4 pillars of safety, traffic safety intervention, as well as the reasons for the public health approach to motor vehicle injury prevention. Essentially it's a huge burden on the public health system, and then we also have strategies that we know we can put in place to at least begin to relieve some of that burden.
We do have 2 additional questions for you, so I'm going to ask you the first one, and then I'm going to move us over to the presentation just so that I'm not taking up too much time. But once we do get over there, I'll ask the last question as well. So the next question comes from John Shaw, and it is, how do the intervention CDC advocates relate to Nitsa's efforts?
We actually partner with Nitsa on a number of things, which is probably not a surprise to the people in this audience, given the overlap here. We do some similar work to Nitsa, and we partner on those efforts as we can. Like I said earlier, a lot of our work is focused on the behavioral side of things and looking at it from the public health perspective and really using the medical and health-related data sources to inform what we're doing. And then we have a lot of our health perspectives on evaluation and implementation of interventions that we bring to bear on the issue. So we partner with them. We try to complement each other and not duplicate efforts. So I don't know if that answers the question.
No, I think that was a great answer. But John, if you do require further clarification, if you can just put it in the chat pod, and we'll make sure to ask that again. Oh, nope, he said that's perfect, so thank you. The last question we had for you is the CDC working on any kind of evaluation model for highway safety professionals to use to determine effectiveness of their work on the human factor side?
Specifically for an evaluation model to use, I'm not sure. We do a lot of evaluation here at CDC, and so there are certainly resources, and that's not even limited to the injury center in our work, but this is just an important part of CDC in general. So there may be resources that I could dig up for you if you wanted to follow up with me. And then in terms of determining effectiveness, we do try to look at effectiveness of different interventions related to all of the priority areas I looked at. And hopefully this next section of the presentation might point you towards some tools that you can use for that.
Perfect, thank you. That is the end of all the questions that we have so far, so I'm going to have you go ahead and start the next section.
Okay, great.
Thank you.
Thank you. Okay, so now I want to move into talking more specifically about the resources and tools and programs that can support transportation safety efforts in rural communities that we have here at the CDC. I'm going to preface this by saying I'm going to share a lot of different resources with you, and there are links to all of these at the end of the presentation, so don't feel like you have to scribble lots of notes, related to what things are and where to find things and all of that. You'll have links to everything at the end of the presentation. So first, what do we know about motor vehicle-related injuries and deaths in state, local, and rural communities? So one of the things that we do here at CDC is research and surveillance, and we are always undertaking these activities. The first thing I want to talk about, though, is the recent report in our Mmwr surveillance summaries on rural and urban differences in occupant deaths and seatbelt use among adults. And this ties into the series of rural health reports that are being published throughout CDC over the course of this year that I mentioned at the beginning of this talk. This is a report that we just published in support of that effort in September. And I'm just going to give a quick kind of overview of what we found without going into too much detail on the methods and all of that. Well, first of all, so instead of looking at a two-level variable, just kind of comparing urban areas to rural areas, we tried to look at that in a little more depth because we know that rural areas are not all the same. So we used a 6-level rural-urban continuum going from kind of highly urbanized areas to across the board to the most rural communities, and looked at occupant deaths and seatbelt use across each of those levels. And what we found was that as rurality increases, occupant death rates among adults also increase. So they're highest in the most rural communities compared with less rural communities. We also found that the proportion of occupants who were unrestrained at the time of the fatal crash increased with increasing rurality. And we looked at some self-reported data from a general population of adults, and these were not crash-involved persons. This was a general population survey, and found that seatbelt use decreases as rurality increases. So beyond that, we wanted to look at the effectiveness of primary seatbelt enforcement laws compared with secondary enforcement laws in the rural communities. So we know in general and that primary seatbelt enforcement laws are more effective than secondary enforcement laws. I believe that this audience is probably familiar with those two different types of laws, but if not, just somebody can type a question in and I'll spend some time on that. But we wanted, a lot of those evaluations have taken place at the state level because these laws are often implemented at the state level. We wanted to see kind of what is happening in rural communities. And what we found is that even in the most rural areas in the United States, that primary enforcement laws were associated with higher levels of seatbelt use and also with lower occupant death rates. And that was true for each census region except for the South. So we reported our death rates by census region rather than for the United States overall because there are some important differences across regions. In the Northeast, the Midwest, and the West, we did find this protective effect of primary enforcement seatbelt laws associated with the occupant death rates. In the South, we had an unusual situation because there are 17 states in the South, and only one of those states had a secondary enforcement law. So we don't feel like we had a very robust comparison between primary and secondary enforcement itself in the South, because we were only, the secondary enforcement category was populated by only one state. But nevertheless, what we found was kind of the opposite of what we expected in the South. So there's a lot more information about that specific finding in the report itself. I don't want to spend a lot of time talking about it right now, but I'm happy to discuss it at any point with anyone. But overall, broadly speaking, we found protective effects with primary enforcement in rural areas. And just to give you a visual of some of these findings, this shows the passenger vehicle occupant death rates per 100,000 population. Again, this is among adults, and these data are presented by region. And what we have across the bottom row here is, on the left-hand side, we have our most urban areas, and these are counties that are located in metropolitan areas of at least 1 million people. And then as you move across to the right-hand side of the chart, we get to the most rural communities. And these are counties that are either completely rural or have a very small urban population of less than 2,500 people. And you can see that for each of the regions, passenger vehicle occupant death rates do increase as we get more rural. Okay, next slide shows self-reported seatbelt use among adults. And again, we're looking at this for each of those 6 categories of rural and urban setting. Again, with the most urban settings on the left-hand side of the slide and the most rural settings in the right-hand side. And what we find here with the dark blue bars, those are the overall levels of seatbelt use for each of the rural-urban categories. And seatbelt use is decreasing as we get from more urban to more rural. The other interesting thing about this slide, I showed the difference in primary seatbelt use in communities with primary versus secondary enforcement at each of the levels of rurality and urbanization. And you can see for each one of these categories that seatbelt use is higher in the primary enforcement areas than in the secondary enforcement areas. And again, that's true even in this most rural setting. Okay, so turning to some different tools that anybody can use. These are all available to the public and to professionals working in the area. I want to talk about some of the different tools that we've got in terms of kind of quantifying what the problem is. The first of these is Whiskers, the web-based injury statistics query and reporting system. This is created and maintained by the Injury Center and is available on our website. Whiskers has information on several different things. The first is fatal deaths from all causes, and these are data that come from the death certificates, which is the National Vital Statistics System. Data here are available at the national, state, and county level, with the caveat that when we get down to the county level, depending on the outcome you're interested in, there may be fewer than 20 deaths, and in those cases, data are suppressed for confidentiality reasons and for concerns about having unstable estimates. So with that said, there are a decent amount of data that can be produced at the county level. You can also run queries by rural and urban status. on the death information. Whiskers also has non-fatal injury data. These are injuries that are treated in emergency departments, and the data come from the National Electronic Injury Surveillance System, All Injury Program. This is NICE is the system that is operated by the Consumer Product Safety Commission, and CDC supplements that funding to run this All Injury Program component to add data on motor vehicle injuries to their data collection system. So this gets us a lot of good information on non-fatal injuries. It is only available at the national level only based on the way that the sampling frame is constructed. And finally, just a couple of years ago, we added cost data to the Whiskers system. And so it's now possible to estimate costs from any fatal and non-fatal injury types, including motor vehicle injury prevention. And these estimates can be produced at the national, regional, or state level. Now I just want to show you a couple of outputs from some different queries just to give you a more concrete example of information you can get from Whiskers. This is unintentional motor vehicle traffic deaths and death rates for 2015 for the United States, and I've simply broken out the data by rural and urban status. So we can see that in the non-metro areas, the age-adjusted death rate at the far right-hand side is about 19 deaths per 100,000 people, and that's about twice the death rate of the metropolitan areas where the death rate's almost 10 deaths per 100,000. We can also get output in the form of maps from Whiskers. This is these are the motor vehicle traffic deaths, these are death rates by state. And these are color-coded by whether the state has a low death rate in comparison with the rest of states or whether they have higher death rates, with the highest death rates shown in this kind of dark orange color. So you can get a sense of which states have higher death rates than others, and these are state-level data, but we can kind of see just from looking at this overview that states with large rural populations tend to have higher death rates. And this is another example of traffic death rates at a state level. I just chose Montana for this output, and you can see here where we're kind of running into some issues with small numbers, where the data have been suppressed. Those counties are marked with the black and white hash marks. But where we can get data, there are some data available at the county level for traffic death rates in the state of Montana. I'm not familiar with all of these counties, but I'm sure the Montana folks can kind of look and see what's going on in some of the different communities. And here I just expanded that query for the state of Montana. These are death rates from all injuries, so all causes, all injury causes, and we get a little more data for the state of Montana. Okay. One of our other tools that's available at CDC is the Behavioral Risk Factor Surveillance System. This is a CDC-funded, sponsored system. It operates in all 50 states and DC and the territories. It's a health-related telephone survey of adults. It's been operating continuously since I did not write this down, but I think in 1985, around then. And there are more than 400,000 interviews completed each year. So it's an extensive, huge data source on a number of different health-related risk behaviors, chronic health conditions, use of preventive services. For our purposes, there are data collected on alcohol-impaired driving and seatbelt use every 2 years. And we use that data extensively here at CDC in terms of monitoring and trends, evaluating state-level interventions, identifying populations at risk. It's a very in-depth, useful data source. And in fact, this was the data source that I used for the rural health MMWR data that I presented earlier on the self-reported seatbelt use data. Okay, BRFSS also has an online query system. You can query the system for prevalence and trends data on any of the health outcomes, including those injury outcomes, or injury behaviors, I should say. And those are available at the national and state level. There's also something that they call SMART, which is the Selected Metropolitan Micropolitan Area Risk Trends data, and there are some local area estimates that are available in this data source, and it depends on the number of respondents that participated in the survey at the local level of whether or not you can get data out of there. But that's a queryable system, and you can look and see if your community of interest is in the system, and if it is, you can get any of the data from the BRFSS. This is the result of just one of the queries that I ran to give an example for you. This is state-level data on self-reported prevalence of driving after drinking too much in the previous 30 days. And again, we've got the states are color-coded by whether they have a low prevalence or higher prevalence of self-reported driving after drinking. And these are percentages. So the dark blue bars, or excuse me, the dark blue states are the states with the highest percentages of respondents who reported that they drank after driving too much in the previous 30 days. CDC also has the Youth Risk Behavior Surveillance System, or YRBSS. This is somewhat similar to the BRFSS data in terms of health-related content and behaviors that are being examined, but in this case we're doing school-based surveys with students who are in grades 9 through 12, and it's administered every other year. Not every state participates in this survey, but there are, in the most recent survey administration, there were 32 states who participated. There's also territories, tribes, and local surveys conducted. And for the transportation safety topics that are measured on this survey, there are questions on riding with a driver who was drinking alcohol, driving after drinking alcohol, texting or emailing while driving, seatbelt use, and bicycle helmet use. And here we have some results on seatbelt use from the YRBSS, and this shows us across the states. The green states are those who have primary seatbelt laws, and you can see where the how they plot on this chart. And the blue states are seatbelt use, shows the seatbelt use for secondary law states. And then the orange is a special case of states that have secondary seatbelt laws, but with the teen driving conditions that they have a provision that provides for primary enforcement for teen drivers. Okay, so this kind of wraps up our segment on tools and resources that are available in terms of establishing kind of the magnitude of the problem in different communities. And now I want to turn to, now that we understand the magnitude, what can we do about motor vehicle related injuries and deaths? And fortunately, there are a wide range of evidence-based interventions that are available. One of the things that we're excited about here at CDC is a tool that we developed, that was released just a couple of years ago, and we're calling it Mbpix. That's the Motor Vehicle Prioritizing Interventions and Cost Calculator for States, which is a mouthful. So how does Mbpix work? It's an online query system, just like some of the others I've already covered, and it helps state decision makers prioritize and select from a suite of 14 evidence-based interventions. And the interventions that are included in the tool were select based on the type of intervention, what it covered, what kind of data we had on the effectiveness of the intervention, the state's role in implementation, because most of the data here are driven for state-level use, and then also the current use of the intervention. So in other words, we wanted to include interventions that actually had not been widely adopted, that might be under consideration by different states and communities. Because, for example, the .08 blood alcohol content driving laws are in place in all 50 states. So we didn't feel like there was a reason to include this into a tool that is really designed for people to use and look at, what else can they be doing. So basically, this allows states to choose from all of these 14 different options. In many cases, we know states, just like any agency or organization, often have to prioritize options based on their resource availability. And this allows a little bit of insight in terms of making setting those priorities. So the 14 interventions that are included in the tool include red light and automated enforcement, speed camera automated enforcement, alcohol interlocks, sobriety checkpoints, saturation patrols, bicycle helmet laws for children, motorcycle helmet use laws, high visibility enforcement for seatbelt and child restraint booster laws, primary enforcement seatbelt laws, vehicle impoundment, license plate impoundment, limits on diversion and plea agreements, increased seatbelt fines, and in-person license renewal for adults age 70 plus. And so I'll also say that we are hoping that we'll be able to periodically update the tool. When it was originally released, we had 12 interventions, and these 2 have just been added in the past year. So our cost-benefit calculations are basically based on the costs are calculated from the monetary costs of implementation of the intervention, as well as costs that are paid by individuals to states. The benefits are based on the number of injuries prevented and lives saved, as well as the monetized value of those injuries prevented and lives saved. And our data sources came largely from published articles and reports for both cost and benefit information. And then our costs, we also supplemented with interviews with state officials and safety experts. We have 2 types of analyses that can be conducted in the Mbpix tool. One is what we call the basic cost-effective analysis, and this shows the entire list of the 14 interventions with cost and benefit information, with numbers of lives saved and injuries prevented at the individual intervention level. And then we also have what's called a portfolio analysis, and a state can set, say input, that if they have a given budget of X amount of dollars, and they can run the tool, and the tool will show for these X number of dollars, kind of these are the interventions that could be implemented simultaneously and kind of get you the biggest bang for your buck. So this is a quick, simple set of output that I got from running one of the queries, and I just did the simple query, the individual intervention estimate. I did this for the state of Kentucky, and I looked at alcohol interlocks. So you can see in the top table here, the intervention that I selected, the first column is candidate intervention, and you can see that I checked off alcohol interlocks, and that row is showing in yellow. The second column shows currently implemented interventions, so that, you know, if I'm considering different sources, then for the state of Kentucky, for example, I don't need to choose and consider those interventions that are already being implemented in the state. And then we have the cost-effectiveness ratios for each of the interventions shown here. Moving down to the bottom table, these are the summary results of the interventions chosen. So again, I only chose one intervention just to kind of keep this simple for discussion purposes. But the total cost of implementing alcohol interlocks is estimated at $115,000 per year. The total benefits in terms of monetary benefits in terms of lives saved and injuries prevented is estimated at $43 million per year. And that represents 23 deaths prevented and 825 injuries prevented. I'll also say that one of the things that we're working on with this tool is to provide more user-friendly output so that this can be taken by users and shared more easily with interested stakeholders. So keep an eye out for that update to be put in place. Okay, so that's our Mbpix tool. I want to turn now to state-based fact sheets that we've developed, and these are all available for all 50 states and DC. And we have fact sheets on restraint use, alcohol-impaired driving, and also costs from motor vehicle crash deaths. And again, these are available for all 50 states. This is part of the alcohol-impaired driving fact sheet, and this particular example is from Michigan. Our fact sheets were created using the latest in communication science. We did lots of usability testing on these, multiple iterations of that. And so we ended up with what we hope is a very user-friendly, valuable tool. We have kind of clearly stated purpose of each fact sheet at the beginning of each one, kind of one attention-grabbing statistic, presentation of data at the state level for comparison to rates in the United States as a whole, and then not only kind of quantifying what the problem is in the state, but also identifying, you know, what works to address those issues. And so we have each fact sheet has a list of interventions that could be put in place to address, you know, in this example, to address alcohol-impaired driving. I want to turn now and talk a little bit about our tribal work. As I mentioned at the beginning, tribes are one of our priority areas. We have a really interesting and I think valuable relationship with Indian Health Services. We have had an Indian Health Services staff member, a staff person who is located in CDC and sits on the transportation safety team. And we've had that arrangement in place for about 30 years now. And we consider that to be really essential to the success of our tribal partnerships and program work. It's just been a really great partnership. We also, I mean, in addition to this IHS partnership that we have with the staff person, we've partnered in the past or currently with Federal Highway Safety Administration, BIA, and others who are working on tribal health. So one of our highlights from this program has been the Tribal Motor Vehicle Injury Prevention Program, which was funded from 2010 to 2014. And the purpose of this program was to implement tailored evidence-based strategies related to alcohol-impaired driving, child safety seat use, and seatbelt use in different tribal communities. So 8 tribes were funded to work on this issue for a 5-year period, and they selected which specific areas they wanted to focus in on. And these were very successful programs, and we were really excited about everything that was accomplished with this. And if you want to read more about any of those kind of particular case studies looking at the eight tribes, a lot of that information is available on our website. And then at the end of that 5-year period, we were really challenged by the CDC director to, see how we could expand our reach in this area. So we had funded 8 tribes during this 5 years, and our IHS staff person really thought about, what could be done and how we could expand the work. And so there was a partnership in place with Federal Highway Administration and to provide technical assistance to states, to tribes, and to work with them on a kind of a higher level so that we could provide technical assistance to a much larger group of tribes. And so we were really happy about that. And then we've also developed some resources that are currently available on our website for any tribal communities to use. And I'll talk about those here. The first is called the Roadway to Safer Tribal Communities Toolkit. This is a toolkit that focuses on restraint use and alcohol-impaired driving prevention. It's tailored to tribal communities. There are a number of fact sheets that can be downloaded and used. There are posters that can be distributed. There's a video kind of highlighting the topic and the issue. And that's, again, it's all on our website. And this was a collaboration between CDC and IHS staff people. And then our other kind of big resource that we have available is the Best Practices Guide for Tribal Motor Vehicle Injury Prevention. This is a guide for tribes, again, and it really focuses on successful motor vehicle programs in tribal communities. What are the lessons learned? We have case studies throughout the guide. And this was a really big undertaking between our CDC program, IHS, and BIA as well. And so we're really proud of that work, and hopefully that is something that can be a good resource for folks. So that pretty much covers the resources that we have that are specific to motor vehicle use, motor vehicle injury prevention. But I did want to close by saying that we have 2 other funded programs, and these are funded more broadly by the Injury Center to deal with injuries from any cause. So it might include motor vehicle injury, and it just kind of depends on the program. But I'll highlight these for you as well, and these may be other resources. The first is called the Core State Violence and Injury Prevention Program, or Core SVIP. This is a program that provides funding and technical assistance to 23 state health departments. And those health departments that are funded set their own priorities in terms of what areas they want to work on. So it may be motor vehicle injury, it may be something else. The states that are highlighted in purple on this map are those that are currently receiving funding for the Core SVIP program. And there is information on our website in terms of kind of contact people to find out more about what any particular state is doing. And then related to the Core SVIP program, we also have what's called a regional network collaborating organization. And this, again, was a challenge to the program to figure out how we could expand our reach. With our, there's a given amount of resources for funding state health departments, but how could we kind of expand to others? And so this was some creative thinking by others in the Injury Center to, in addition to the kind of base funding that each health department receives for the core SBIP program, one state in each region, and these regions are defined sort of loosely according to this particular program. But there are 5 regional network collaborating organizations. And these are, the purpose really here is to provide some coordination across all states in the region around injury and violence prevention, and that would include unfunded states. So the idea would be for the RNCO to kind of lead some regional activities like networking and mentoring opportunities, trainings, webinars, that kind of thing, so that they can kind of expand their reach and partner with unfunded state injury prevention programs. And also in the fall of 2017, and now, this is getting ready to roll out, and we are implementing something called the National Peer Learning Teams. So they're different from the regional network organizations in that they're not organized geographically, but the peer learning teams will be organized by topic area. So there will be, for example, one national peer learning team that focuses specifically on motor vehicle injury prevention, and that state is going to be Massachusetts. So I would say stay tuned for what's coming through that program. We're really excited about this and the opportunity to kind of connect state partners with each other, states that are interested in motor vehicle injury prevention. And then the last program I want to mention are our Injury Control Research Centers, or ICRCs. CDC funds 10 of these academic research centers, and they have 3 core functions. First is research, as the name implies. So again, this is each research center sets its own priorities and may or may not be working on motor vehicle injury prevention. But in addition to research, they really also have an outreach component, and the purpose there is to work with states and communities to kind of put research findings into action. So these are a potential resource for local communities to work with. And then also another core function of the ICRCs is to provide training for the next generation of injury prevention researchers. And here is a map of the ICRCs. The orange states, or gold-colored states, are the states where the currently funded ICRCs are located, with the names of the universities written in next to them. And then the blue states are those that are previously funded, but they're not currently receiving any funding. So that wraps up a lot of information. I feel like I've thrown all kinds of different things at the audience, and I hope that there are different tools and resources that will be useful to you. Like I said at the beginning, I've got a list of all of the resources here on these slides, so you can look up anything in particular that you might be interested in. And I'm happy to take questions. Oh, I also wanted to close here and mention that we do have another webinar coming up in November, and this is a webinar that HRSA is organizing in coordination with CDC, HRSA, the Health Resources and Services Administration. And they're conducting a series of webinars to highlight the findings that are coming out from the CDC Mmwr rural health reports. So previous webinars are online at their website, and this November 15th webinar will focus on the 3 injury-related Mmwr rural health reports, including the one on transportation safety, and we'll also have information on opioids and suicide. Thank you very much.
Perfect. Thank you very much, Laurie. We do appreciate you taking the time to speak today, and I know we do have another question and answer section, and we have a lot of questions coming into the chat pod. If anyone has any others, please go ahead and put those in. We do have one more poll break that I'm going to move us over to, and then we'll address all of those questions that have come in. So the last poll question that we have for you guys is, which of the following are CDC resources, tools, and programs to support transportation safety efforts? A website dedicated to rural health and rural communities, the web-based injury statistics query and reporting system, the Rural Morbidity and Mortality Weekly Report, data on restraint use and alcohol-impaired driving from the Behavioral Risk Factors Surveillance System Survey, Mbpix system, the state-based fact sheets on restraint use, alcohol-impaired driving, and costs from crash deaths for all 50 states, a Tribal Motor Vehicle Injury Prevention Best Practices Guide 2016, the Injury Control Resources Centers, all of the above, none of the above, or I don't know, and I don't remember. I also do want to just point your attention one more time to the bottom left-hand corner and the handout section. All of the links that Laurie did put together for you guys in those final couple of PowerPoint slides can be downloaded. They're available in this PDF of the presentation that's available in the handout. So if you do want a copy of all of those links, go ahead and download that PowerPoint presentation, and you'll have those. It will also be posted on our website along with the recording from today's webinar. So it does look like everyone has gone ahead and answered the poll, so I'm going to go ahead and close that for you, Laurie. You should be able to see it now.
Thank you. Yes, so it looks like everyone answered all of the above for the resources, tools, and programs, which is great. And I hope that these are useful for you. And I have links to all of those on those resource slides. So hopefully everybody can get to anything that they need and get more information. And I'm always available to answer any questions.
And speaking of questions, we do have several for you, so we'll go through those one at a time. Your first one is from John Shaw, and it says, will it be possible in the future to get information about non-fatal motor vehicle injuries at the state and local level?
That's a great question. We would love to have that data. So the reason it's not available now is because our data come from NICE, the NICE system, which is operated by Consumer Product Safety Commission. And so they have a sample of about, I think it's about 66 hospitals across the country. And these are hospitals with emergency departments. And they're just, the sample design is just not set up to represent, be representative of states and local settings. And in fact, they're not even hospitals in each state. So I don't know that there are plans in place to change that system. That would be a huge change to the operation of the system and the funding of the system. So I can't say that that's going to be available, readily available. So most of the data that we see on non-fatal motor vehicle injuries at that level come from special studies that are conducted at universities or other settings.
Our second question for you, Laurie, is from Jerry Roche, and it's, some of your interventions showed a negative cost. Does that mean that they generate revenue?
I don't want to answer that question incorrectly. I was not involved in the project management on the Mbpix tool. There are some other people on our team that would be able to answer that question immediately. So I don't want to answer the question incorrectly. I will say that on the Mbpix tool, in addition to kind of all the information I showed about how to run the queries and which interventions are available, there are also links for each of the interventions that provide some of the background and more information about what each of those interventions are. And so the answer to that question may be available there. And if it's not, I will look it up and get it to you.
And Jerry, if you wouldn't mind, I did put Laurie's email address in the chat pod a little bit ago. If you could send her that email, she can follow up with you. It'll also be on the very last slide of today's presentation as well, too. The next question for you, Laurie, is are all of these tools that are available able to be filtered for specific age groups, primarily for stats on children and infants?
The data on, so from Whiskers, which is the Injury Center's kind of query system on injury-related deaths and the non-fatal injuries, those are available for specific age groups, including children and infants. Some of the others are not, and that depends, it depends on which data source you're talking about. So, for example, the Behavioral Risk Factor Surveillance System only interviews adults. So that data is available only for adults. The YRBSS data is available for high school students. So it kind of depends on the data source.
Okay, perfect. The next question is from Matt Warren, and it is, what is the CDC doing to address distracted driving?
Sure. So a lot of the work we've done on distracted driving is focused on, I would say, the early stages of that public health model that I showed at the beginning of the presentation, where we're, assessing the problem. So we have done some surveys and reported at the national level, the proportion of people who report distracted driving. We've also done, I believe we have a report out that, I don't remember which countries, but comparing U.S. reports of U.S. reports of distracted driving to those in some other Western European countries. So we've done a little bit kind of on the assessing the problem side of things, and that's kind of where we are right now with that. And I say we being CDC. So.
And it looks like the last question that we have for you is from someone named Nick, and it is, the current research centers all seem to be in the East. How does one apply to become a center, and are there any key requirements? It seems a center specific to rural traffic safety is relevant.
You're right. They are all kind of in the East right now. I don't know why that is. It's a competitive process, and I believe the funding is probably provided. These are probably 5-year funding announcements. Stat Systems operated out of a different division, so I don't know much in terms of detail other than they are academic research centers that are interested in injury. I would have to look up at the last announcement to find out the specific requirements. I know some of them do traffic safety research, but you're right that we don't have any that are in real rural communities. And I don't know what the qualification criteria are, or the evaluation criteria, I should say, in terms of selecting centers. I don't think that was an intentional thing that all of the funded centers are in the East. I suspect that's just how in terms of both the applications and evaluations of applications, that's kind of how they fell out this time.
It looks like we had a couple additional questions coming in for you too. We have another one looking for some data. It says, based on police reports, Nitsa says there are about 2.4 million motor vehicle injuries annually in the U.S. If I downloaded it correctly, Whiskers indicates the total is around 3.5 million. Do you have any thoughts on the reasons for the difference?
Yes, I do. I'm glad you asked that question. So I mentioned early on that, they're kind of, broadly speaking, sort of two sources of data on motor vehicle injuries and deaths, and one comes from crash reports, and that comes in through the Department of Transportation, and then the other are kind of these medical records systems, and that's what populates the Whiskers data system. So it's different methodologies. The motor vehicle injuries that are reported from Nitsa come from crash reports, and so it's, well, in some cases in crashes there are visible injuries and easy to sort of recognize and for the officer to mark that. And then in other cases there are people who may not be visibly injured and may decide later that they're sore, whatever happens, and then they end up in an emergency department setting, getting checked out for an injury. So that is kind of part of the discrepancy. It would be interesting, I think, to undertake a really much more in-depth look at, kind of what's driving all of that. But it really boils down to the fact that we've got two different data collection methods. The other thing that I want to point out in Whiskers is that it also includes, Whiskers has a setting to report whether the injury occurred in traffic or not in traffic, or include all of those injuries. So just real quickly, that if you select just traffic injuries, it probably correlates a little more closely to the Nitsa reports, although there's still the discrepancy I mentioned. But Whiskers also includes injuries that occurred not in traffic, which are technically not collected on the police crash reports. So those might be things that occurred on a, private parking lot setting, or, anything like that that's considered not in traffic.
Thank you. Those are great reasons why there may be a discrepancy between the two. Lastly,
I'm sorry. If I could just add one more thing. I think this is another kind of reason why data linkage is so valuable, and I think it kind of help us with some of these questions and concerns.
We did have one more person put in a comment about the research centers and them all mostly being to the east. Kara mentions that she's from the University of Iowa Research Center, and they do transportation safety research and are the most western one currently. It's a 5-year funding cycle for the research centers, so the makeup of the geographic distribution will likely change after the next funding cycle. So that's just some additional information on those research centers and the question that Nick had posed. Okay, I'm going to go ahead and wrap up our webinar. The learning outcomes in this webinar are to summarize the public health approach to motor vehicle injury prevention and to identify the CDC resources, tools, and programs that can support transportation safety efforts in rural communities. I do want to thank Laurie for speaking with us today and for sharing all of her valuable resources that she has. We had some great discussions. The question and answer periods were fantastic, so thank you everyone for the questions, and Laurie for your very thorough answers to all of them. We do appreciate it. As we mentioned before, at the bottom left-hand corner again is the handouts, and that does have those slides on there with all of the links to the resources. There are a few upcoming webinars to let you guys know about, and there's actually a couple more than the ones just showing on your screen right now. We will have all of these that I'm about to mention posted on the homepage of our website, and they also have been in our training e-blasts and will continue to be so that you can grab the information about them. On October 25th, there is an upcoming webinar on respectful workplaces and health and safety empowerment for women in trades. The information for that will be up on our website. On November 8th, there is a webinar being hosted by Nitsa and FHWA on tools for tribes to improve crash data. Again, later today, that will also be posted on the homepage of our website. On November 15th, as we've mentioned before, there is the next Safety Center webinar on achieving safety results by addressing behavioral issues. And there is also the webinar that Laurie mentioned earlier, which will talk more in depth on the Mmwr that she talked about today. And so more information on that can be found through the slides, and we'll post that on our website too. November 30th, the Safety Center will be actually hosting a second November webinar that month, and that one will be on unpaved road safety. And lastly, our December webinar will be on the culture of the Swedish Vision Zero, and this will be a guest speaker from Sweden coming to speak with us about that as well. So I know that's a lot of webinars to let you know about, but again, they're all going to be on our website for you to get more information. We do, as always, have the training videos, one on the introduction to road safety culture and one on the introduction to tribal road safety audits, available on our website and our YouTube channel. And again, if you do have any questions, please feel free to reach out to Laurie at the following email that's showing on your screen, or you can contact us at the Safety Center and we'll get you in touch with her as well. So one more time, thank you very much, Laurie. I really do appreciate you taking the time today to share all your resources with us.
Thank you. I really enjoyed this opportunity.
Everybody have a great afternoon, and the webinar should be posted on our website within the week. So thank you.